Hello, everyone. Welcome to another edition of Surgery Live. Thanks for being here. We've got a great episode here today. With that, I'd like to introduce my good buddy, Dr. Tommy Curran from the Medical University of South Carolina. Dr. Curran and I met when we were touring the country for our fellowship interviews, and we've been in touch and been good friends ever since. He's going to be talking to us about ready, set, wait, surgical management of Crohn's enterocutaneous fistula. So, Dr. Curran, I hand it over to you.
Thank you for that introduction, Dr. Rosen. I am ecstatic to be here this morning, so I'll bring up my presentation. I am presenting from sunny Charleston, South Carolina, though it is currently 70 and fluorescent in my office. So I have no disclosures. We'll start off, we have a 61-year-old gentleman who has known penetrating Crohn's disease. He came to us from an outside hospital with intra-abdominal abscesses concerning for enterocutaneous fistula. A bit about his presentation. He had been having difficulty with tolerance of oral intake, though he was passing gas and stool. He had several months of failure to thrive with an associated 25-pound weight loss. Over that period of time at another hospital, he had undergone multiple antibiotic courses and IR drain placements for intra-abdominal abscess. For several months, which I'll get into in a moment, he had been off all Crohn's-related medications and really came to us with recurrent fever and abdominal pain despite having an IR drain in place. In regard to his IBD-specific history, he was diagnosed in 1999. He presented acutely to an outside hospital with perforation. He underwent laparotomy and small bowel resection. He then was off treatment for many years until he re-presented to an outside hospital in 2013, similarly underwent open small bowel resection. At that point, he was started on adalimumab and seemingly did well for about 6 years, and then had that stopped for issues with basal cell skin cancers and started on ustekinumab, though after just one dose, he had a reaction to the medication, an infusion reaction, and that was halted. He did poorly over the subsequent several months, followed by an outside facility. And in May of 2020, he underwent laparotomy with small bowel resection for multifocal abscesses. They describe a prolonged lysis of adhesions, large rind and cavity in the retroperitoneum. And then following that, on postoperative day 5, he developed intra-abdominal sepsis, was taken back to the operating room with diffuse succus, and he had resection of the small bowel anastomosis and the remaining terminal ileum, and underwent an ilioascending stapled anastomosis. So this is the circumstances under which he presented. On examination, he was hemodynamically essentially normal, though fairly cachectic appearing. He had a soft abdomen with mild tenderness and succus coming from both the IR drain and around it. A photograph of that is here. He was leukopenic with an elevated CRP, anemic and hypoalbuminemic, and ultimately his blood cultures grew out Candida glabrata. So I'll pause here, and as Dr. Rosen said, we want this to be interactive, but I'll show his CT scan for a moment. So here we'll see he has this very large kind of central abdominal dilated, blown out previous small bowel anastomosis. He has a drain in place in the anterior abdominal wall. And then going over here, they highlight a small kink, and here's his ileocolic anastomosis with some free fluid in the retroperitoneum. So with that, I'll pause and take some inputs. How would folks go about managing this enterocutaneous fistula? And then also, what about the medical and surgical management of Crohn's disease in the setting of active infection?
I think those are some great points, Dr. Curran. This is obviously a very challenging case and something that we can all face. So I'll start with one of our star chief residents going into colorectal, Dr. Val Vilches. Val, what are some, just, ignore the Crohn's for just a moment. Talk about, can you tell us about some basic tenets of management of someone who comes to you with abscesses like Dr. Curran described, malnourished, some fluid collection, some sepsis. How do you go about wrapping your head around this? Do you run to the OR? What do you do?
So I think there is a couple of points that you have to take into consideration. One is control of the sepsis or the infection before you plan to go to the OR or do any type of surgical intervention, and then optimize the patient nutritionally. I think those are points that are really important when you're dealing with patients with enterocutaneous fistula before you decide any other next approach at that point.
Yeah, I think those are great points. And, it's not lost that probably that was an issue that this gentleman had in his previous surgeries with that anastomotic leak. I think those things kind of played a role with that. So now looking at the Crohn's aspect of things, Dr. Hollabar, as our lead in IBD, and if you're on and able to comment, is there anything that you need? So we talked about controlling the sepsis. So if there's if there's fluid collections that can be percutaneously drained, broad spectrum antibiotics. We'll get into nutrition a bit, but how about, is there any medical therapy that we should be initiating right away? Steroids, biologics, how do we go about figuring that out?
Yeah, no, there's no role for medical therapy for the inflammatory bowel disease at this point. The patient has developed a certain postoperative complication. I would take a step back and go back to the original operation and think about with the setting of the operation, and making an anastomosis in the presence of intra-abdominal sepsis is prone to result in this complication, because the anastomosis, which is somewhat mobile, is going to be magnetized, if you will, to the rind, and it's going to result in a leak. So this is somewhat predictable. So you want to make sure you get your anastomosis away from any sepsis, and or not make one. The anastomosis that is not made will not leak. Or consider proximal diversion. We published a paper a couple years ago about high-risk ileocolic anastomoses, and if you have to count up the risk factors, and it doesn't really matter what the risk factors are, but you count them on your fingers. If you have 3 strikes, you're out, and you got to either divert the patient or bring out an endoileostomy. But no, his Crohn's is going to have to take a back burner until you control the sepsis.
And how about, so great, thank you very much. So, and are there any strategies, Dr. Steele, do you have any strategies with these fistulas where, how do you, a lot of things that bother the patient personally is their skin gets very raw, it leaks everywhere, it's a mess. Are there any strategies that that are effective for controlling that drainage that these patients have?
Yeah, thanks, David. Tommy, good to see you. Thanks for doing the case. I love that green tie. So the first thing I would say is the fact that I think for a lot of the junior people on there, the first thing you have to say to yourself, is the patient acutely sick or not? If the patient is acutely sick, then all bets are off and you got to do whatever is done. But if they're not sick, you got time and we can go down. So don't ever lose sight of that. That's the first question you should ask yourself. Because if the patient's sick, then all the wound care and all the other things that goes out the door, and you got to be able to try to control that sepsis. So we're blessed by having a lot of enterostomal therapists that have a long history of taking care of these wounds. When I saw the images, they looked like they were both very small openings. It didn't look like you had an enteroatmospheric fistula, which you have to get creative on some of these patients with an open belly. So it's important to distinguish enterocutaneous fistula versus an enteroatmospheric fistula. And enterocutaneous fistula, obviously, we talk about what's going to have a high output versus a low output, categorizing that using stoma bags, using stoma base like you would to be able to build up something around it. But sometimes, David, it just goes back to saying, what's coming out of it? How does it respond? We always talk about if you can feed the gut, should you in a stable enterocutaneous fistula versus somebody who's sick and you got to intervene on. But again, sepsis management, controlling the wound, having the output, rehabilitating that patient, getting them through nutritionally, studying the fistula, and then doing a definitive operation is your typical management that we typically talk about for enterocutaneous fistulas, with that varying between how stable the patient is. And for the wound management, specifically what you told me, again, if it's high output and it's really close to the skin, you can't get anything to stick, the first thing you have to do is be able to protect that skin, use barriers, build that up, and use bags. And if you have to keep NPO and on-TPN, do that. If you can use oral PO through this strategy, that's the best.
Great. I think that sets us up perfectly for our next part of our presentation. I think so, as we went over a few things that Dr. Curran's about to get into here, exactly what Dr. Steele and Dr. Vilches and Dr. Hollabar are talking about. We've got to be thinking about nutrition, we've got to think about high versus low output, how do we control this thing, and controlling the sepsis. So Dr. Curran, I'll give it back to you.
So fantastic comments all around. So now moving on, this more so for the residents, and a lot of this was highlighted by Dr. Steele. This is a table from Dr. Leitner and colleagues, a wonderful review of management of penetrating Crohn's disease, quantifying the output, and then some of the pillars of managing this. So over the subsequent couple months, our fantastic interventional radiology colleagues were able to place a drain adjacent to the anastomotic leak that facilitated capture of the majority of his fistula output. He had a line holiday during which he received broad spectrum antibiotics and antifungals. He then had a PICC replaced and TPN initiated. His drain output then went down from about 750 cc's a day to less than 100, which permitted him to leave the hospital on TPN. In the following couple months, as he recovered from his acute illness, he was initiated by our GI IBD team on infliximab, and his drain really dried up to almost nothing. In January, he had an IR drain removed after a negative drain study and several weeks of no output. But somewhat predictably, a few weeks later, he was readmitted with abdominal pain, spontaneous midline drainage. He had an essentially benign exam at that time, though remained relatively cachectic. He had normal white count. He was persistently hypoalbuminemic. And the output from this sinus, this enterocutaneous fistula tract in the lower abdomen, was about 25 to 50 cc's a day. This is actually the point at which I met him. And at this stage, I felt that I needed to prepare him for surgery to obtain definitive control, but felt that he was not in condition in this moment. So I'll show once again his CT scan to show how this evolved. So at this stage, this is prior to, or rather at this time without any drain in place. There's again this big dilated, blown out portion of proximal small bowel. You can see the tract having matured through the anterior abdominal wall, going down now into the retroperitoneum, where there's this phlegmon of small bowel and the anastomosis really tethered to the right retroperitoneum. So
Dr. Curran, I forgot, you said he was gone home on TPN. Is he eating at all? Is he just on TPN?
Oh, that's a great point. So at this stage, he had actually been weaned off of TPN, and he was eating essentially a low residue diet with his at what had been a dry drain for several weeks. So now at this stage, I was thinking the options would be surgery now, TPN to tune him up, and exclusive enteral nutrition, by which mode of administration. So I'd love to hear thoughts from the group on what people are doing for this type of patient.
Great. Dr. Hull, you obviously have a vast experience with treating Crohn's disease, and here's a gentleman who, he's been very sick. His fistula has now been converted to low output, 25 to 50 cc's a day while eating, but his albumin is only 2.3 from 2.0. What would your thoughts be on how would you now proceed with his nutritional status and getting him ready for surgery, or do you think he's ready at this point?
So the first thing that strikes me is I would be surprised if he's getting much nutrition with that hugely dilated bowel. You see this in Crohn's, that they tolerate eating and you have this humongously dilated bowel, but realistically, how much nutrition are they getting from it? My goal would be getting him ready for surgery. And I'm sorry, when was his last surgery? His last abdominal surgery?
This is his last surgery was in May, done at another hospital, and now we're in January.
Okay, so
About 6 months, 7 months.
well over the 6-month mark, so that's good. My thought would be that he needs to be NPO, try to decompress this bowel a little bit so you don't, to make your job easier when you're going to operate. I would give him TPN, whatever it takes. I wouldn't be feeding him with that hugely dilated bowel. Most of these people I consider a G-tube in, because you want that bowel to get decompressed. You're going to have a hellacious time anyhow. It's not going to be a very easy operation, and then you have that hugely dilated bowel. So if he came to see me in the office and had that CAT scan, I would feel there's still work to do before he's ready for surgery. You're not going to get his albumin up probably, because he's got this big mess that's just taking all of his, metabolic nutrition, in his abdomen.
Would you let him eat in addition to the TPN, Dr. Hall, or not at all?
He looks like he's almost totally obstructed. That's huge bowel that's upstream from that, it looks to me like. So, why would you keep stretching it out? It's going to be this balloon when you get in there anyhow. You're going to have trouble you may have trouble not making a hole in it. You're going to have to decompress it, and you're going to have to worry about it spilling all over. I would want to try to decompress it before, naturally, without having him eat, and seeing if you can get this to go down a little bit. I'm surprised he doesn't have a peg. I'm surprised he's eating.
Dr. Brad Sklow, do you agree? Does this large and dilated anastomosis, does that scare you from feeding the gut? Are you thinking TPN as well? Do you think, he's eating and having bowel function, so maybe you can do some enteral nutrition? Do you have any thoughts?
I'd be thinking TPN. I don't think you can feed that bowel.
Dr. Hollabar, what do you think? Same thing, TPN? Anyone want to do, Dr. Steele, anyone want to do enteral nutrition?
Yeah, I agree with the comments said. I do want to make a shout out to the Chevy Chase Spies Like Us in the bottom. For those of you who didn't catch that was a very nice touch there, Tommy. But the only other thing that I would say is, to go along with Dr. Hall's point, is that even if you do that, recognize that some of this bowel, when you let it go long, it will stay that way for a very long time, and you will radiographically, you'll see chronically dilated bowel, and it just never goes back. And that's problematic, because you're not going to get absorption from there to, just like Dr. Hall said. And then your nutritional aspect, you're working, and even feeding them enterally is not helping them, even if they may tolerate it.
All right, so we got a lot of votes, Dr. Curran, for TPN. I think I would say also that, obviously his absorption is or seems to be impaired, as his albumin is not making a lot of gains with him eating. We do know there are also risks, though, obviously, that come with TPN, line sepsis, cholestasis, thrombosis. So it's not always a free lunch. And I think that's always a difficult decision we have in these patients, whether to, try to go with enteral nutrition, which when possible, we would prefer, but sometimes you can't for other reasons, as we discussed. So why don't you take it over from here, Dr. Curran, and see what happens next.
Absolutely. So those are all excellent points, and things that I considered at that time. The chronicity of his dilated bowel had been quite long-standing, looking at scans from his prior institution. And so I actually went with enteral nutrition, exclusive enteral nutrition, which has robust data in the pediatric population, evolving data in adults. In brief, this from a review a couple years ago, elemental versus semi-elemental versus polymeric, really no differences. And the level of data is really case series level. But based on that, we went that route. A couple things about picking the right patient for this type of therapy. So it does require significant adherence. And so this is a study from a group in New Zealand looking at the personality traits of people who adhere to this, finding that conscientious patients are the ones that complete the therapy. So if you have a conscientious patient, if you have someone like the good Dr. David Rosen, they're going to be having this for breakfast every morning. After the fact, my patient told me that he ate a little bit of this on the side, but nonetheless, in a 6-week period, his weight went up 9 pounds. His albumin went up to 3, a decent improvement in his prealbumin as well. And so at that point, went to the operating room. What I encountered was significant adhesions as expected. It was a prolonged lysis to clarify the anatomy and identify the anastomosis. There was an extensive phlegmon in the right lower quadrant, which was tracking to the midline. There was a visible anastomotic defect as the source of the fistula. The tract itself was very well defined with extensive granulation tissue and local soft tissue destruction. Ultimately, I resected 21 centimeters of the neo-TI, including the ileocolic anastomosis. And at this point, he had approximately 150 centimeters of small bowel remaining after that resection. Importantly, the big blown out previous small bowel anastomosis was about right in almost the middle of this, about 60 centimeters from the stapled end. And so this was somewhat of a quandary. So I'd love to hear from the group what folks would do. Would they put him back together? If so, how would they do it? What maybe would they consider doing a diverted ileocolic, or just go endoleostomy with or without a mucus fistula?
Dr. Hull, what are your thoughts here? You know, the albumin's up to 3, the prealbumin's 24. You've got 150 centimeters of small bowel left, including that dilated bowel. What would you do here? Put them together, divert, straight ileostomy?
So I missed it. What's the tissue like? Did you get the whole tract out? We heard about what the fistula looked like, but are you able to get the whole area out? Is it soft? Does it look healthy?
I would say that none of his small bowel really looks healthy or well. It's all kind of chronically thickened, and the tract was very aggressively debrided. All the granulation tissue and things, there was somewhat of a limited rind remaining, but I was not enthusiastic about the health of the remaining bowel.
So if you're not enthusiastic about the health, I would say an ileostomy, put the distal end as close as you can so that when you go back, you can just do a limited circle, hopefully around the stoma, and put it together and come back another day. He only has 150 centimeters. You're going to guarantee him probably TPN plus your enteral feeds. But I think that the goal now is to try not to make him a short bowel person. So, and if he has another leak, that's a bad strike. So I would be very conservative.
Dr. Skloud, do you agree endoleostomy? Would you think about putting them together and diverting? What do you think?
No, with that quality of the bowel that he described, I'd do what Tracy suggested. Endoleostomy, mucus fistula, the colon right next to it, so you could do a limited takedown in the future.
And Dr. Hull, one other question for you. Say he was healthy and that quality was excellent of the bowel. What type of anastomosis would you do here? What's your standard go-to for Crohn's disease, where you're going to have to do an ileocolic anastomosis? Are you a side-to-side staple? Are you end-to-side, a Cono-S?
Absolutely not side to side. And we had a good IBD live yesterday that demonstrated why, because it just, to me, it's just not the good way to do it. Now, I know a lot of people do things like Cono-S's. For straightforward ileocolics, I tend to do what Dr. Lavery taught us to do, an end of small bowel, end of side of colon, because you can scope that, and it's been a really reliable anastomosis. For somebody like this, I would strongly consider a hand-sewn anastomosis. We don't do enough of those, and I think that when you look at the studies, and hand-sewn do not perform as well, it's because people don't sew anymore and they don't do a good job. And the fellows that are our fellows that are on the call know that I'm always harping on them. You got to know how to sew. And this is a perfect example if you had to sew. So I would probably consider a hand sewn versus a stapled in this person.
And those is your staple technique. Are you doing that with an EEA end side with the anvil and the small bowel?
Yep, I had to think about that for a second. Yes, and it's usually a 28, and then you can insert betadine through the colotomy and make sure it's watertight, so it gives you the ability to check it.
And then for your hand sewn, are you doing isoperistaltic side to side, or how are you doing, or end to end, or how are you doing that?
End to end with cheetal extensions if you have to. The back wall is turnbull mattress, and the front wall is 3/0 Vicro seromuscular.
Dr. Steele, what's your reconstruction option of choice for ileocolic anastomoses and Crohn's?
Yeah, on these redos, I've been going to Cohen OSs recently, which gives you the opportunity to learn how to staple, as well as then you can also do a hand-sewn anastomosis with it. So it's a little bit of the best of both worlds.
Great. All right, Dr. Curran, take us home.
Okay, so the stunning conclusion, fantastic comments all around. I will kind of speed through some of these. They will be forever available for posterity on the Surgery Live website. But a couple things, some of the data that had been referenced early on by some of the experts on the call. So Dr. Halabar mentioned the 3 strikes and you're out. This is from NSQIP review. Our patient had 3 strikes that landed him an ileostomy. As to other risk factors, this is also from the group there in Cleveland, noting the importance of albumin, some of the risk factors from Mayo and from the Leahy Clinic for multiple resections being at increased risk. And then as Dr. Hull pointed out, the risk of intestinal failure often due to intra-abdominal sepsis in these Crohn's patients. The role of right-sided diversion, really undefined. But I should highlight that I trained under Dr. Bradley Sklow at the University of Minnesota, and I did exactly what he just described. I created an end ileostomy. I matured a portion of the transverse colon stapled end into the stoma trephination as a partial mucus fistula, hopefully to facilitate a more limited reconstruction down the road. This gentleman left the hospital on postoperative day 6, but you pick your poison with these patients. While we avoided intra-abdominal sepsis, he did have a readmission for high output ileostomy, which we managed effectively, but we lived to fight another day.
Fantastic. And one thing we didn't talk about, Dr. Curran, I'll pick your brain on before we end, what was his medication status going into surgery? Was he on any steroids or biologics? Do you typically hold those? What's your thoughts there?
That's a great question. He was off of all steroids. He was on infliximab, and I have not been routinely holding biologics for surgery. I think he was about 10 days beyond his most recent dose, 10 or 12 days. So not right after, but closer to the middle of the interval.
Yeah, I think that's something historically we did. We were worried about the risk of biologics and wound healing. More recent data has shown that not to be as much of a risk or concern as we initially thought. So I think that's probably the standard that most of us are changing to.
So, you know,
anyone have any?
Yeah, I was going to comment. The paper that we published that came out, so it's probably not the biologics, it's probably the steroids. And when you go way back and you look at the initiation when we started to use Remicade and some of the damning evidence that came out of that got applied to Remicade, if you really tease it out, Caitlin Ritter did that, and we published it a couple years ago. It's really the steroids, and as you look at a lot of these studies that have been published that probably were not as accurate as in retrospect, if you look at their steroids, that was probably the thing. If you really go through some of the published studies from Mayo, etc. So I have gotten a lot more. Dr. Fozzi used to say 15 to 20 milligrams of prednisone, you don't have to worry. And I really changed my thought process about that based on really looking at those studies and the study that we published.
So do you have a number then, Dr. Hull, that you choose if it's not 15 to 20 you're not worried about?
So my first thought is I don't want them in a flare. So, some patients will come in and they can't get below 30. And so I'd rather have them at 30 than in a flare. And so then you're going to be a lot more, in my opinion, a lot more conservative. So you're going to consider stomas, even if it's jejunostomies above anastomoses or not doing anastomoses, etc. I think the lowest amount you can get, I think you have to look at the whole situation. Just saying I'm going to wean them off and then have them in a full-blown flare, I think that's worse. So I think you have to, be smart about it, be a doctor, and look at the whole situation.
Great, phenomenal points. And yes, thank you for clarifying. I was referring to the biologics being less of a concern, but steroids obviously are a really bad thing for wound healing. Dr. Curran, I'll give you the final word. Any final thoughts on anything we haven't talked about or anything we have?
So this has been a tremendous opportunity to present to this group. If I have one regret, it is that I think I owe Dr. Sklow a drink for not finding a way to use the word proboscis in this presentation. So maybe at a future ASCRS. Well, thank you to everyone. This has been great. To our host, Dr. David Rosen, and to the Cleveland Clinic.
Thanks, Dr. Curran. And what I've learned is any challenging case like this is best sent down to Charleston. We can provide you with Dr. Curran's contact information for any difficult cases. But thanks, Tommy. Thanks so much. Thanks so much for everybody for a great conversation. We'll be back here right next week, April 16th at 6:45. Dr. Tony DeRoss is going to be talking about an anterior mediastinal mass in a 16-year-old, which will be fascinating, I'm sure. Very difficult case. I can't even imagine trying to do that anymore. As a monthly reminder, Surgery Live meets every Friday except the first Friday, and we rotate through all the general surgery subspecialties. Thanks again to our corporate sponsor, Medtronic. Thanks for our participants, to Dr. Curran. I'll see you next week on Surgery Live.